Let's jump straight into this clinical explainer. We're tackling a sudden, high-stakes ward deterioration where literally every single second counts. Welcome to today's clinical staff briefing. We're walking through a highly realistic patient simulation focusing on the acute neurological deterioration of our patient Arthur Penhaligon. Our goal here, to map out exactly how you assess, intervene, and escalate when you're staring down a potential acute stroke on the ward. We need to be structured, we need to be lightning fast, and we need to execute this flawlessly. Let's get into it. Now, the core clinical mantra that's got to drive absolutely every action you take here is pretty simple but incredibly powerful. Time is brain. You've probably heard this phrase a million times before, right? But in the context of a new onset focal deficit, it is the absolute golden rule. I mean, millions of neurons can die for every single minute a stroke goes untreated. So the speed of your initial recognition and your response on the floor, that directly correlates to Arthur's chances of survival and his long-term functional outcome. Bottom line, we absolutely can't afford to hesitate. Okay, let's set the scene and put you right there in the room. Arthur is an 85-year-old retired watchmaker. He was initially admitted to the general medicine ward after a mechanical fall. His baseline admission data looked okay, a Glasgow Coma Scale of 14, and crucially, his initial non-contrast CT brain scan showed absolutely no acute hemorrhage. But then, things change in a flash. You walk into room 5 at 2:15 p.m. Arthur is slumped over in his chair, he spilled a jug of water, he looks acutely confused, and as he tries to talk to you, you notice his words are heavily slurred. So what do you do in this exact moment? We have to act immediately, and that takes a highly structured approach. Which brings us to Section 1, assess using the FAST pathway. To quickly identify acute focal neurological deficits, we rely on the structured FAST assessment. We're not guessing here, and we definitely aren't just assuming he's tired from the fall. Looking closely at Arthur's results, he is positive across the board. For his face, you're observing a very clear right-sided droop. When you test his arms, you find significant right arm drift and profound weakness. We're talking 0 out of 5 power, literally a complete lack of voluntary muscle movement on that right side. And for speech, like we noticed earlier, he has distinct dysarthria or slurred speech. Make no mistake, this is a definitively positive FAST assessment. It paints a very clear, highly concerning picture of a sudden neurological event. Compounding those severe neurological signs, you grab his vitals and immediately see that he's highly hypertensive. We're looking at a blood pressure of 195 over 105 millimeters of mercury. Now, this elevated BP is a massive red flag, but it's actually a really frequent physiological response during an acute stroke as the body desperately tries to push blood to perfuse the brain. It's a critical observation, and you absolutely need to note it down for the medical team because it's going to heavily dictate whether Arthur is even a candidate for acute treatments like thrombolysis later on. Moving right along to Section 2, intervene. Let's look at some critical safety steps and common pitfalls. Now, before we lock in our clinical picture and sound all the major alarms, we've got to rule out dangerous clinical mimics. A super common pitfall in ward nursing is hypoglycemia. It can perfectly mimic acute stroke symptoms. Think about it. A sudden drop in blood sugar deprives the brain of its main energy source. That can cause focal neurologic deficits, things like unilateral weakness, confusion, slurred speech, that look virtually identical to an ischemic event. Because of that exact reason, you have to check his blood sugar level immediately. You've got to rule out that mimic. Now, you might see his emergency department baseline from earlier was a perfectly normal 6.8 millimoles per liter, but do not let that give you a false sense of security. Clinical states change rapidly, right? You need a fresh capillary blood glucose reading right now at 2:15 p.m. You need to confidently tell the responding medical team that this is a true neurological event, not just a metabolic crash. Okay, so while you're rapidly juggling this assessment, another hazard suddenly pops up. You notice Arthur's well-meaning wife, Joyce, standing right by his side. She sees him looking groggy and slurring, and naturally, she just wants to help. She tells you, I'm just giving him some tea to help him wake up, and she actually attempts to give him some fluids. This introduces a massive, life-threatening clinical hazard smack in the middle of your assessment. You must empathetically, but very firmly, stop her and enforce strict nil by mouth or NBM status immediately. Remember, Arthur has a right-sided facial droop and dysarthria. That tells us the muscles controlling his mouth and throat are compromised. If he takes even a sip of that tea, he's at a tremendously high risk of aspiration, choking and pulling that fluid directly down into his lungs. That could trigger aspiration pneumonia or a severe airway obstruction right on top of a stroke. So you need to take control of the room, reassure Joyce, but ensure that absolutely nothing goes into Arthur's mouth. Let's pull all these immediate bedside interventions together. Alongside that strict NBM order and the rapid blood sugar check, make sure you position Arthur upright at about 30 degrees. Elevating the head of the bed does a few things. It helps protect his compromised airway, drops the risk of aspiration, and actually helps optimize venous drainage away from the brain. But, and this is a big but, always ensure you only do this if his blood pressure tolerates it and he isn't hypotensive. Given his BP is currently 195/105, elevating him is definitely the right call here.
All right, that brings us to Section 3, escalate and initiating the code response.
So you know it's a stroke, and you've kept Arthur safe. Now you need the experts in the room ASAP. Clear communication during a crisis like this is absolutely paramount. When that responding medical team bursts through the door, they need a concise, incredibly accurate picture of exactly what went down in the last few minutes. To do that, we're going to utilize the structured isobar handover format for a medical emergency team call. This is the gold standard for clinical handovers because it makes sure no critical piece of information slips through the cracks when you're under pressure. Let's break down exactly what that actually sounds like on the floor. You'll deliver the handover systematically. First, identify the patient. This is Arthur Penhaligon, 85 years old. Then, state the situation. He has sudden onset acute stroke symptoms, specifically right-sided weakness and severe dysarthria. Next, detail your observations. His current GCS has dropped to 12. His blood pressure is critically high at 195/105, and he is fast positive across the board. Then, give the background. He was admitted for a mechanical fall, but crucially, he has a history of untreated atrial fibrillation and hypertension. You know, that untreated AF is a massive clue pointing straight towards a clot. Then provide your assessment. My assessment is a likely acute ischemic stroke, and his airway is currently at risk due to an impaired swallow. And finally, state your request. I am requesting a code stroke protocol. We've stopped all oral intake, and we need to prepare him for immediate repeat CT or MRI imaging to locate the clot.
And just like that, you've perfectly executed the initial clinical pathway for a suspected acute ischemic stroke. You protected your patient, you ruled out the mimics, and you escalated beautifully. But as we wrap up this explainer, I want to leave you with one final, critical thought to chew on. You've initiated the code stroke, sure, but how would your critical nursing considerations and your immediate medical interventions drastically change if that repeat brain scan suddenly showed a severe hemorrhage instead of a clot? Think about how the entire clinical pathway forks from here. Thanks so much for joining me for this briefing, and stay focused out there.